Hello everyone, welcome back to the Old School RN. My name's Deb. I'm a registered nurse of many years, trained here in the NHS UK. I now run a healthcare and travel business, but this channel is really to highlight things going on in the NHS, to try and explain what goes on in NHS culture, and to look at themes around the news in the NHS, the news in healthcare, and maybe if people have got questions, they can come on and like, subscribe, and ask those questions in the comments section. And I just want to try and put down a history of how things were and how the NHS has changed over the years. And my aim is to not just document the history of the NHS, but to enable people to work through it, all around it, which is gradually what I'm sort of trying to build up to. Anyway, Lucy Letby, part 2. I did address this very briefly when there were lots of doubts cast over Lucy's trial. I've been following this really closely. I've always thought there was something not quite right about how she was treated, but certainly how the news that's transpired from nurses who've worked there, and I'm going to come to one in particular, has sort of shown a different side to what has happened with her. One thing I will say as a seasoned nurse in the NHS is that since business took over, business managers, the NHS has never been the same. And I mean that in a sincere way. Once upon a time, we didn't have business managers. It was administrators, it was nurses, it was doctors, and the NHS ran very, very well, as we were. We were good communicators, we worked as a team, and we did the best for the hospital. And we were like family. I mean, we were a small hospital that I trained in before I went to bigger teaching hospitals. They're different again. Yeah, it's a whole other story. But we were like family. We lived in, most of us. We went out together. We went for restaurants, for meals, etc. We had a social club. We all knew one another quite well because it was only a small hospital, and you made a lot of friends. And it was a nice time. It was a nice time to be young as well, because it was the 80s. Don't even get me into the music, because I'll never shut up. Anyway, Lucy's training is completely different. Lucy was in a cohort from what is called Project 2000, and that was a change in nurse education, which became more university-based, less nursing school-based. In fact, I think nursing schools were closed down then, or closing. And the apprentice style, salaried, you belong to the hospital and the hospital teaching staff, had almost disappeared, because universities taking over, of course, takes the student nurses out of the clinical arena. And what it does is it stops those nurses from learning hands-on. So instead of having theory in the nursing school and then putting it into practice under supervision, that's gone. So I used to have, up until recently, and even like going back a few months, I'd have student nurses who couldn't even put a drip through, just run it through, i.e. put the line on, run through, check there's no bubbles, and hand it to me to connect to a drip cannula in your hand or your arm. They didn't know how to do that because the university didn't allow them and didn't ensure them to do these tasks. Whereas I was doing that, after my initial training on a ward, and connecting the drips safely under supervision at first, and then as you became more senior, like a year, second year, third year, you were left to get on with it, basically, because you were deemed as safe, having been assessed. So Lucy's training was very, very different, and Lucy was probably only one of a couple of nurses who were working full time. So she appears on the off duty a lot because she wasn't just full time, she was doing extra hours because the nurses that were there didn't have the skills and competencies that she had. She actually went to Liverpool to learn more advanced nursing roles around sort of neonates, babies, so that she could give certain drugs, certain infusions, certain drips, and she had that skill set and she was relied upon a lot. So she was always working like 60 plus hours a week. So I want to just look at some evidence that was presented by an advanced nurse practitioner in neonatal care or baby care, a lady by the name of Michelle Walden. And she gave an interview on another channel called Lucy Letby Case Exposed here on YouTube. Absolutely brilliant interview, brilliant. Now, Michelle has trained a bit like me. She did her RGN. She then went in to become a midwife, as a lot of people did, or you go into your specialty. For me, it was adult intensive care. We did some children, we did some babies, but it was predominantly adult intensive care and A&E, and cardiothoracic, so chest and lungs. I'll go into that another day. So I understand that critical care environment. So like me, Michelle was advanced in her practice. So she's sat a course, she's been supervised, and she's able to prescribe, perform advanced procedures on patients, and she's a very highly skilled, highly educated member of the team. Now, she was working at the Countess of Chester Hospital and had been for a long time. So she knew the culture, she knew the department, and she understood neonatology very, very well. Now, Michelle has outlined how she was sending emails and raising concerns to the Assistant Director of Nursing and Director of Nursing and the Trust Management about the changes in education and the lack of staffing and skill mix. It's okay saying, oh, you've got 5 registered nurses looking after intensive care patients or whatever, but if they don't have the skill set to give certain drugs, to understand certain medical conditions, you're then relying on like one person per shift to be doing their own tasks, doing their own work, caring for their own patients, supervising you, and taking on other roles because those other nurses haven't got that competency. So Michelle, I'm just going to do little bits of this because Michelle's interview is quite long. So what Michelle was saying was, because she qualified in 1988, she too has had over 35 years experience. So she really understands what's going on. And in her email, she was saying how staff morale is very, very low, how career development is being stifled, that sickness and exhaustion, physical and mental, is on the increase, and that because there isn't enough skilled staff, they're having to cover and do more shifts in order to keep the unit as safe as possible. Not as safe as it should be, but as safe as possible. And all these staffing concerns were raised time and time again, and it appears to be the case that it's being ignored by management. Okay, so one of the things that she was concerned about was nurses' education and nurses' development in their career, because if you're not developing people in their role and teaching them new things and helping them to understand that role and be involved in care and take on new tasks, being able to, advance in your careers to become a senior staff nurse, junior sister, learn management, teaching courses, it's a hard role, because to be utterly clinical is exhausting mentally. If you have something else that you can do, i.e., family liaison, teaching, putting on teaching sessions for student nurses who are, say, visiting the unit, who are doing their general training, specialist staff nurses who are new to the unit and orientating. All these people have specific teaching needs. Management, going along to meetings, going along to clinical audits, sitting in multidisciplinary team meetings with doctors, physios, you know, lots of other people who are involved in patient care are vital to your role as a nurse. So the burnout was quite high, and nurses were going on to higher paid roles in other hospitals once they had the training and experience. Well, you don't want that. You want to keep those skills, not frighten them away by saying we don't have any career advancement for you, no training for you. You want to foster and develop those staff and care for them, just like you would your patients. But since we've had this culture change in the NHS, i.e. business managers being brought in, that has gone. That today, by today's standards, that has gone. It started to go in the 2000s. It's definitely corroded from 2010 onwards. Since 2020 and COVID, I would say it's virtually non-existent. That the nursing role has been reduced to time, target, especially in A&E, and getting patients seen in chunks of time. Well, people don't react like that. You can't say, oh, after 2 days, a patient's going to do this, or 3 days, a patient's going to do that. In intensive care, whether it's children, babies, or adults, they're up and down over periods of days. You're not looking at hour by hour or 24-hour periods. You're looking at over the course of a number of days, ideally a week. You will see a trend. Is that trend up and down and going upwards and the patient's getting better? Or is it going up and down and plateauing and on a downward trajectory? Patients are needing more drugs to keep their blood pressure stable, keep their ventilation stable. Is the oxygen increasing? Are the ventilator settings increasing or decreasing? There's a lot to look at. Plus, you've also got the parents and the families of your patients to guide them. They're in a completely alien environment, and they're reliant on you as their nurse to help them through that, to teach them and guide them into understanding what's going on with their family member. It's stressful for them, and you as a nurse are taking on that stress and internalizing it. You can't help it, you're human. Excuse me, but you're doing that day in, day out, as well as being professionally competent and dealing with, you know, the effects of drugs, because you don't just give a drug, you're assessing how it works. Does it work? Are there any side effects? Are there any contraindications with other medications that are causing problems for the patient? Does anything significant in terms of the patient's observations change after that medication? So their pulse, their blood pressure, their temperature, their oxygen levels. Is there any other therapy that is needed after a medication's been given? And a good example of that is intravenous antibiotics, because critical care patients do react to antibiotics being given. But that's a whole other video. I mean, that is a subject in and of itself. So what I'm trying to say is that nursing is a very skilled, especially in critical care, skilled and complex role. It isn't just a case of we'll put a nurse in there who's worked with the elderly or in community. Intensive care is absolutely draining. I know, because I was working in it for a long time in various roles and levels. So in neonatology, it's even more so, more emotive, because you're dealing with babies. And having spoken to neonatal nurses and children's nurses, I used to say to them, you know, how can you look after children and babies so much? It must be heartbreaking. And they used to say to me in turn, I don't know how you can look after adults of all ages, because they've got a life or had a life, and dealing with that is quite intense, whereas children may not understand, depending on age, and they haven't had a life as such. So it's more of a, they've not experienced the world. So children will always stay children regardless of the outcome. So again, this is a way of nurses coming to terms with how they're dealing with illness and death, because there is sadly a lot of death and demise in intensive care, whether it's young babies or adults. It's hard. So back to what Michelle had said, I'm trying to give some context around this. Michelle was saying that a lot of patients, because you develop, the families develop rather, a very strong rapport with the nurse that they're working with, and they tend to have their favourites. It's not that they don't like nurse A and prefer nurse B. It's nothing to do with that. It's to do with who gels on a personal level with them, who's had the most contact with that child. So you will have other patients, again, whether it's children, adults or babies, but you will gravitate to some patients, because if you've taken a patient from the day they've been admitted and met the family and developed that rapport, you tend to stay with them throughout that time. And the family begin to gel with you and understand you and trust your judgment, especially if you explain, again, old school, explain to them what you're doing, how you're doing it, why you're doing it, and what the outcome of that intervention will be. For example, using the intravenous antibiotics as one example, I used to explain, that there will be some changes in blood pressure, and I'd draw a very small diagram if it was necessary, and try and explain why these things happen, so that people could be prepared, and that the alarm settings I put into the ventilator and into the displayed physiological measurements, so heart rate, blood pressure, temperature, etc., it will alarm, because I've set strict parameters around the numbers, so that if there is a change and I'm busy doing something, I will be alerted. Yes, I'm watching all the time, I'm watching the monitor, I'm watching the blood pressure, etc. But I've also got that backup. And a good intensive care nurse knows what's going to happen before alarms go off. So it's something of an art with a science, and that art and science are closely interwoven. It's a very, very complicated role. So what Michelle has done, by emailing the trust and making them aware that the staff are still being professional, but are tired, exhausted, etc., because they're dealing with parents and children, what has happened is the trust have used, it appears in this case anyway, to have used as a stick, shall we say, the fact that parents, families and the nurses had a very close relationship. Now, what happens in hospital culture, and more so probably with babies than adults, although it does happen with adults, is that when somebody dies, because you've got close to the families will invite you to the funeral. And it's a lovely thing. It's such a kind thing for them to do, because one, they want your support. Two, they trust you because you've been part of their life and cared for their loved one. And it's an honour. It's actually an honour to be that close to the family and still maintain your professional boundary. I've been to funerals of patients who've died, and been in the wake with the family and talked with them. And often things will arise. They'll ask a question. Do you think this? Did this happen? Do you think they'll understand? This has happened. Do you think they were in pain? That things crop up, and they will ask you questions, so it gives that family some clarity and closure. Sometimes it'll be a case of they just want to be heard, so they know that you understand what's gone on and you're just a listening ear. So you are there to comfort them. It's an unpaid professional role, and some people might say, well, why would you be doing that on your time off? Really, it should be part of a paid role, and I think the government and a lot of managers don't understand this, but this is about being human. You don't go into an NHS role or any kind of service thinking that it's not going to affect you, because it does. Of course it does, especially when you're very, very close with people, and you get to know them as people, and you are, what's the word, you're not just a professional friend. I think it's more special than that. You're a reminder of a time in that family's life where you were pivotal in your care for that family member, and part of the memory process, and part of helping them with their bereavement. For example, with adults, each Christmas we used to have a gathering for those who wanted to attend, of families who would come back, whether their loved one had died or whether their loved one had got better, because a lot, people do, a lot of people get better as well. And they would come back and recall about their time in the intensive care unit, and come and share, some coffee, tea, some sandwiches, whatever. And we used to have that every year. And one of our staff nurses used to run a really good group. She qualified as a counsellor, and she used to sit and talk with the patients and give them like some debrief, because there are a lot of mental and emotional changes that take place in patients, more so adults, after they've been in intensive care, such as near-death experiences, hallucinations for some who are coming off morphine and other anaesthetic drugs that has kept them sedated. And it's quite a profound life experience. And again, it's a human experience, because they want closure. They want to talk to you about it, because nobody else is going to understand, even if they were there, like other family members. So that complex role, and grateful families sending you letters and cards and giving you boxes of chocolates. Always at Christmas we used to get loads of chocolate sent to the unit, and cakes and things like that. It's so sweet, it's so lovely. And the letters were very heartfelt, written from the heart. And what Michelle was trying to get over to the managers is that these cards and letters from families are an appreciation of your care and your devotion in your role that money can't buy, to a point. I still agree that we're still underpaid for the role and the responsibility that we have, but that's, again, another topic for another day. I could write reams and talk reams about this. But those families pour their heart onto paper and thank you for being there for them. Now, Lucy Letby had cards and letters from families. She did go to children's funerals, babies' funerals, and she was very, very well thought of by many, if not all, of the families of the children that she was caring for. And yet, the trust managers have weaponised those letters and those cards to use against her. Another thing she had were notes. Now, all nurses make notes about patients at a special time at the beginning and end of a shift called handover. So you're handing over from one shift to another. So if I'm on night duty, I'll turn up at 7:30. I'll get a handover of the whole unit, and then I'll get a more in-depth one of the patients that I'm caring for, or patient. So I tend to write bed 2, 22-year-old male, some other feature like a hospital number or something like that, or just a first name. And it'll be, don't forget, this drug is changing at midnight. Don't forget to check the blood sugars are now hourly or 2 hourly instead of 4 hourly. Or can you ask the pharmacist in the morning, we're running low on whatever drug, antibiotic, whatever. Can we take blood for certain antibiotic levels in the morning, hand over to the day staff? Now, these notes are kept on a piece of paper, And that's literally what they are. It's an aid memoir. It's a reminder to do things. Some of them will be patient specific. Some of them will be housekeeping. You know, get the estates in to fix the light above bed 3, or you know that the door lock isn't working properly on the office door, or whatever it is. You have these notes, especially when you're in charge and senior. So it's not uncommon to fold these up and put them in your pocket. And normally when you get home, you go, oh gosh, okay. So you'll put them all in a bag or in a pile, take them into work, and they go in the clinical waste bin, which is burned. Clinical waste is always burned. So it's not identifiable information. If it is, it's always binned straight away before you leave. But today, because you're so busy, it's not uncommon to go home with the drug keys, to forget to tell somebody something, or to have these notes in your pocket. Now, Lucy had kept them in a bag with the aim of returning them to the hospital. We've all done it as nurses. I don't know a nurse who hasn't done that, because you know it's safe, it's sealed in a bag, you take it to work, it goes in the clinical waste, and it's burned. I used to have an open fire in my house, so all my notes used to go on fire. So I know, you know, they were destroyed, or a shredder. Some nurses had a shredder. So whatever it was, we all had our own way of, you know, maintaining professional confidentiality. Now, Lucy had some of these old notes, so I'd call them contemporaneous notes. And the police, of course, have seen these, and that has been used against her. I just find it, I don't know, I can't get my head around it, because why you would use that against somebody instead of understanding it in the context. It's almost like somebody's being set up to fail. If you don't work in the NHS culture, somebody can try and explain to you till the cows come home what NHS culture is about. But unless you're in it, you don't fully get the whole picture. And that's true of anything: police work, ambulance work, paramedics work, banking, whatever. You understand the culture of the work that you're in. So to try and explain it in a court of law or to somebody outside, they'll get a bit of it, but they won't fully understand it. So when Michelle Warden was talking about these notes, I could understand immediately what she was saying. And it isn't unusual for these things to happen. Now, if you bring in people from outside industry, banking, finance, cars, car businesses, football clubs, because a lot of HR managers are from football clubs who come into the NHS, they will see a hospital in a very, very different way. I'm all for talking to people who are from the outside. It's great. It gives you a fresh perspective and a different sort of viewpoint, and you think, never thought of that. However, that discussion of where some things overlap, where things can be improved, and where things certainly you wouldn't do or think of doing, is not being taken on board. Nurses and doctors are not being listened to, regardless of their seniority. If anything, they're being got rid of, made redundant, bullied to within an inch of their lives, so that they're made to go. They also will have, their promotion prospects taken from them, and it's very subtle bullying. But on top of everything else, with the exhaustion, the shifts, the time, the responsibility, it doesn't take much for something else to be added to that pile of Jenga, whereby it will topple. So bullying in the NHS is a big thing, a very big thing. And what I'm worried about is if nurses are now being set up to fail. Similarly, this happened in Stafford Hospital. Stafford Hospital, the chief nurse was removed as a result of business changes, business practices being brought into healthcare back in the day. I think it was the early 2000s, if anybody remembers the Stafford inquiry. Again, that's another video. Gosh, so many. Because I've actually worked at Stafford and at Stoke. So I know a lot of the inside kind of issues, as well as what the media were saying and things like that. So you can get a sort of helicopter view of the culture and what has actually gone on. But if there is no communication, no dialogue, no regular meetings with the staff on the ground, things can be misinterpreted. And it really is my personal point of view that there is more to Lucy's case than meets the eye. I wonder if things have been misinterpreted, twisted, used as a stick to beat her with, because the issues that were being brought up in emails by Michelle and lots of other advanced practitioners and nurses were largely ignored. You know, you sort of get, oh yes, I will feed that back. Yes, lessons are learned. Yes, we will deal with that. Yes, we understand. But nothing gets done. You never hear anymore. And there are policies and procedures in place to report your concerns and safeguarding concerns and whistleblowing concerns. Again, particularly after the Stafford inquiry, whereby you are protected for bringing up a safeguarding issue or a whistleblowing issue rather. But there are more than one way to deal with matters, and often whistleblowers are given a pretty rough ride. Again, I could cite lots of examples in other hospitals of people in the Midlands who were not treated very well by a certain trust CEO. Again, video for another day, another one. Yeah, I'll leave it there because otherwise we'll be here all day. Yeah, so Lucy, I'm going to summarise all this. I hope I've sort of given some idea on a couple of things that were mentioned about Lucy's case and the context around it. It comes down to the same old thing: business managers. Business managers brought into a clinical service. A service isn't a business. That's why it's a service. People like me and Michelle, or I'm speaking for myself now, I went into nursing to be in a service. I didn't need the reward of bonuses and finances and money and all of that. I had, there was a good NHS pension arrangement in place, final salary. There was, perks, if you could call them that, time off for courses, time off to study. I've mentioned them all before, sort of social club, cut price accommodation. Wasn't luxury, but it was clean and it was, it did the job until you were on a salary enough to get a mortgage back then. But those kind of things made a difference. You were working 8-hour days with paid lunch. Now you work 12, 13, 14-hour days with one unpaid break, split into 2 30-minute breaks to go to the loo. Yeah, to go to the loo, because you don't get a chance. So urine infections are on the increase amongst nurses and doctors too, particularly females. Food and drink, you don't get a chance. You just don't get a chance to get water, a cup of tea, because you're constantly busy because there's, shortage of staff. Chronic tiredness, chronic psychological and emotional tiredness because of the gravity of the work you're doing. And then you add in a business culture, and the two just don't work. And I truly believe personally that this is a theme that's running through this case, and I'm very, very interested to see the evidence that the barrister has recently submitted from neonatologists all around the world. I think that was a brilliant move by the barrister to show that, she didn't commit any crime, that this was something that was bound to happen because of the state of the unit, the medical culture of the unit and the business side of the unit. I'll come back to Michelle's video another time because it was quite lengthy, really, really interesting if you get a chance to see it. And the points that she was bringing up as I'm watching it, my head's nodding, yeah, I get it. Because she, like me, is an old school RN, you know, old school nurses. We were properly trained. And I feel for our new nurses, you know, I wish they had that support and that understanding and career trajectory that we had, because the NHS really was a different place back then. And I'm not saying everything that happened in the past was fantastic, but what I will end on is the fact that a service was nicer to work in than a business in healthcare. And the NHS is precious, and it's being corroded. It's being so badly corroded that stories like this, I believe, are influencing the public. These things are rare, but they're rarely all one way. There's a lot more to this, and yeah, I think I'll leave it there because this video is going to be way too long. Yeah, we need to be a service again, and we need to not lose our precious NHS, because when it worked as a service, it was good. It wasn't perfect, but it was very, very good and cost effective. But now that's not the case. It's a whole new place as a result of those changes. So yeah, right. I'm going to leave it there because I talk forever. Forgive me. Sorry about my last video. I didn't have my microphone clipped on, so I'm chunnering away, talking away, and it was all like mine. So I do apologise for that. I will redo that video and summarise it a bit better. For those who lip read, they understood. But yeah, I've actually got my microphone on today, so, and I've remembered to switch it on as well. Okay, thank you so much for bearing with me if you have, after all this talk. And I want to regularly do these videos because I don't want the NHS to disappear. I'd like to keep it in the annals of history if I can. There you go, I'm chunnering again. So I'll leave it there. Thank you so much for listening, and join me next time. Bye.